Welcome to the Brainstem podcast. This is your host, Dr. Hilary Marusak, produced by Amanpreet Vogel, Manmeet Vogel, and Gabby Maramag. Okay, welcome to our episode on anxiety disorders. I am so excited to have our guest today. This is Amanpreet Vogel, and I'll have her introduce herself in one moment, but she is on the opposite side of the camera today. Usually she is the brains behind the operation. She is so talented, as I think all of you know, at videography and photography and science communication. So she's got really personal and unique experience that she's going to share with us generously today, and also very exciting and innovative professional interests in kind of blending her interest in neuroscience and medicine with the goal of improving people's lives, and particularly youth mental health, and also things like reduced stigma about mental disorders. So her and I collaborated on developing this podcast, and I'm just so incredibly excited to have you today. So first, start by just sharing a little bit about yourself, who you are, where did you grow up, things like that.
Okay, well, first of all, thank you for that amazing introduction. My name is Aman. I'm a research assistant at the Think Lab, and I have been very interested in examining the impact of discrimination in specific on mental health and neurodevelopmental outcomes in youth. I started research back in 2016, met Hilary in 2018, and I've been with her since then. Like she said, I am also very passionate about science communication, so I'm involved with the social media in the lab as well, where we create really cool infographics. I think they're pretty cool on the publications that come out of the lab, and we even have a TikTok as well, where we have different series. We have one on the endocannabinoid system, and we have one coming up on trauma as well.
Very excited to see that and see what you do. She's got all sorts of awesome ideas, so stay tuned for that. So let's talk about anxiety, which is the topic of today. So this is a really extremely common problem. Up to 1 in 3 people have experienced an anxiety disorder at some point in their life. And post-COVID, we've seen an increase in the prevalence and also the severity of many mental disorders, including anxiety. So what does anxiety mean to you?
Sure. So anxiety for me, if I could describe it in one sentence, feels like you're so in your head and you're everywhere but in the present moment. My mind just feels like an endless stream of what if questions. And these what if questions are so heavy and negative and intense that I'm constantly in a state of worry. So these questions can be, say, if my mom's going to a grocery store, my mind will start going like, what if she gets into an accident? What if she dies? What am I going to do? How am I going to take care of myself? And the likelihood of that happening, I don't know how high that is, but my mind really makes me feel like, oh, like that's definitely going to be happening. And when I get into that high state of anxiety, it's so hard to just ground myself and pull myself out of it. Like I feel like I just can't get my mind to stop reeling. And when my mind is working like that, how I'm feeling is like there's nausea, there's a loss of appetite. I'm very irritable. There's just so much to it. And I feel like if someone were to be watching me, what you would see is like I just kind of shut down, like where like I'll just like it's like I'll go from like being this person who's like super happy to then suddenly like there's very little emotion there. And then one thing my mom says that she knows that I'm feeling anxious, like if my leg just starts shaking and I'm moving it up and down, like those are just like the different components for what anxiety is like for me.
Mm-hmm. Thank you for sharing that. And I know you mentioned a couple of like physical manifestations, which we don't often think about because, but especially for kids where it might be harder for them to describe what you so elegantly said, like it's kind of this endless train of thought that is associated with worry. But for kids, they can't really tell us that. So we have to rely on some of these physical manifestations, like a kid who may get a headache or a stomach ache really frequently, or some other ways like sweaty palms, for example, which we've all experienced. But and I know a lot of different people have different kind of manifestations of anxiety. Like some people totally avoid talking about or like even going to places that remind them. For example, people with social anxiety, they might not like going into big social events or parties. Do you have any other examples or things that you've kind of noticed? Because I know you've talked to a ton of people with it. You're very well versed in the anxiety literature.
Yeah.
So do you have any other examples?
So I have generalized anxiety disorder. I also have panic disorder as well. So a lot of my anxiety manifests as panic attacks as well. For me, because of my anxiety, as I was getting better, like this past year was very difficult for me, and you're very aware of that. But for me, just putting myself in new situations and environments, like where I didn't have my mom there and didn't have that support system there, that was a big thing where I just kept avoiding situations like that. I know that coffee is one thing that you'll hear from a lot of people, especially with anxiety. My psychiatrist just completely cut coffee out of my life because coffee, the physical symptoms that you can sometimes have with the caffeine is very similar to how you're feeling when you're in a high state of anxiety, or maybe when you have a panic attack coming on as well. So these are just a few things that I tend to avoid. And then I know what can really make my anxiety much worse. So right now, I'm still working through a lot. So I actually have a boundary set with a lot of friends that I can't be there. If they're going through something super, super heavy, I can't hear a lot about it. Even at work, I'm not involved with trauma interviews because right now that's just one thing I'm not able to do because it can make my anxiety so bad. But I think there's a lot of strength in identifying what are your limitations and in order to really protect yourself and your mental health.
Yeah, and I want to get into that a little bit more as well, because I think you've developed a lot of treatments and interventions and types of strategies that work really well for you. But of course, everyone's different. So that list may look a little bit different for different people. I was just laughing about the coffee comment because I think I told you I'm a little over caffeinated right now. So I'm feeling kind of the heart racing, the jitteriness a little bit. But I think it goes to speak to the fact that anxiety is kind of an inverted U. So we use that term in science a lot, which is that there's kind of an optimal state of things, and you can say, there's an optimal level of anxiety, and then once you get over that tipping point, things kind of get worse. So anxiety is really adaptive. You have to have a little bit of anxiety. The example I always give is if you're not anxious about a test coming up, you're probably not going to study. So you need to have a little bit of anxiety about it. But then, of course, too much can actually be detrimental, and that's where you kind of get into some of these anxiety disorders. So thank you for painting that picture for folks. So can you talk a little bit about when you first recognized any anxiety symptoms?
I would say that it would probably be my freshman year of high school, freshman or sophomore year of high school, but I didn't know what anxiety was at the time. Mental health was just not something that was talked in our household. We weren't aware of it. We weren't aware of it until someone in our family was struggling with their mental health, and then that conversation came up. But I was always described as someone that was super worried. That was the way everyone described me. And once I got my diagnosis and learned more about anxiety, looking back, I'm it definitely started in high school for me. So when I was 14 or 15, which is very interesting because I kind of want to turn it around and ask you a question too.
Sure.
When do we typically see the onset of anxiety disorders in youth?
Yeah, that's a great question. It does kind of depend on the type of anxiety disorder, which you alluded to. So there are several different types. Generalized anxiety, as you mentioned, is a very common one. Panic disorder is also very common. And then it's also common to have more than one disorder. And that goes for things like depression as well, which we'll talk about a little bit. But yeah, you're right that many of these disorders begin pretty early in life. So some kids will show separation anxiety that continues on. And there's different kind of ages of onset of different types of disorders. Like generalized anxiety, we typically see happen a little bit later on. But in general, many of these things begin pretty early in life. The first 2 decades, we start kind of seeing these signs. So we're beginning to conceptualize them as more of neurodevelopmental disorders. That is something that is happening in the brain while it's developing that makes people more sensitive. But again, everybody is different. You can have one in your 30s. You can have one when you're 10.
Right.
All depends.
Okay.
Yeah. No, that's great. So we did talk about the idea of comorbidities, that there are different disorders that you can tend to have. And actually most people that have a psychiatric disorder sometimes have comorbid symptoms or different types of symptoms, like anxiety and depression tend to go hand in hand. So could you speak to any comorbidities you've experienced?
Yeah, so when I was diagnosed with anxiety, I was actually diagnosed with depression first. I got both of them together. I went to my doctor, I think my sophomore year of undergrad. And when I was there, I was like, look, like this is how I'm feeling. And you know how they give you those screening questions? I just got the high score on the generalized anxiety disorder.
You're like,
one.
yes,
I'm
high
like,
score.
Yeah. So did really well on that test. But yeah, so I got diagnosed with generalized anxiety disorder and depression at the same time. And that was my sophomore year of undergrad. And then just recently, I was diagnosed with PMDD, panic disorder, and then the generalized anxiety disorder was there. Depression has thankfully gotten better. But I think I was very surprised this past year because my psychiatrist was explaining to me because my anxiety was so bad that, like, unfortunately, there was a lot of suicidal thoughts and ideation that came with it. And he's like, that is something that individuals with anxiety struggle with. And I think I also kind of wanted to touch on what you said, that everyone experiences anxiety. Yes, everyone does experience anxiety. And sometimes I think at least when I got diagnosed with anxiety, everyone was like, oh, like, well, it's just anxiety. And it's like, yeah, it's powerful to say sometimes that it is just anxiety. But at times, like, anxiety can be so dark and difficult that I think, like, my anxiety took me out for this entire past year. You know this, like, I had to take a medical leave from work, and like it took me, I would say, almost the entire year, but the past 4 months were it's just so intense where I had to work through that anxiety. So yes, everyone does experience anxiety, but there is like that certain threshold that you hit where you know that, okay, like maybe this is too much, like maybe this is not okay.
Right. Yeah. No, and I think that's a really good point too, that a lot of people think, oh, it's just anxiety or it's just ADHD. But in reality, like the severity can vary so much. And we tend to like kind of glamorize certain disorders, right?
Yeah.
Like we've talked about this before with like tic disorder, like, oh, that's so cute. But like in reality, come on. Like,
yeah, exactly. Yeah.
Depends on the person. I think it's interesting that anxiety and depression often co-occur together. And in your situation, it may have for a little bit at least. But those things we know are really heritable together. So if you have like a biological mom who has depression, you're more likely to have anxiety and or depression. So it's kind of interesting that there is that aspect. That's not always true, but they are closely related. And I always think of it, and we'll go back to this a little bit later, but anxiety, what you're describing, is very like future oriented thoughts.
Yeah.
Like you're worried about like, what if, or if I do this, like something bad will happen. Depression, we typically think of as being kind of the opposite, where you're kind of stuck in the past.
Yeah.
So you're like ruminating about things that happen, things you could have done better. The goal is really to be somewhere in the middle and be focused on the present, right? Which is something we'll talk about. But have you experienced kind of that like past and future, or are you mostly in the future?
No, definitely. Especially when I had both anxiety and depression. Like I felt like that's why it was so exhausting, because you're just like everywhere but in that present moment, because my anxiety would make me fixate on the future. My depression would make me fixate on the past and past things that I've done. And I was just stuck thinking about that all the time, that like I didn't even get the chance to like look at my present, and I'm like, technically everything's going right in my life. And that's kind of similar to how it felt this past year too, but it was more future oriented, where like I'm like, everything is going right in my life, but like your mind, like it's like my mind just like it didn't let me see that. It just, because I could not get a break from what was going on with the thoughts, like the nonstop thoughts, and the very like real like physiological component of it too.
No, for sure. And it's kind of interesting too, from a neuroscience perspective. We know that at least for kind of the depression, there is a brain network that we'll maybe talk about later called the default mode network, that we think of as really kind of online when you're mind wandering and when you're ruminating and you're not like focused on that present moment. So we're beginning to have some understanding of what causes that at the level of the brain. But I want to talk a little bit more about how anxiety has affected you personally. You already mentioned work. Are there other aspects of life that this has affected?
Yeah, so I can really focus on this past year specifically. I think it's really tested like a lot of relationships and friendships in my life. For me, I think this is another important thing to touch on. Like sleep is the foundation for good mental health, for me at least. And so I've made a lot of lifestyle changes as well, where it's like sleep is the number one most important thing. I had to rethink certain career choices as well, just based off of like, would that lifestyle fit for the anxiety that I have? Whereas I think like before I used to be like, oh, like, whatever I choose, like I'll make it work. But really this past year was just so difficult that I was like, at least for this year, I need a job. I need to work somewhere where I can prioritize my sleep. I can prioritize those rest periods. And then even in my own personal relationships, like with my mom and with my brother, there were just so many conversations where it's like, just ask me what I need, where it's like, because I tend to get pretty irritable and angry, and I don't want to snap at people around me. So now what I do is like, I'll just tend to isolate, which I think is a very new sort of reaction, because in the past it was like a lot of like outward emotions. But yeah, like with my own personal relationships, I had to have conversations with friends and family. Like, I am going through a tough time. This is what makes my anxiety worse. I had a panic attack when I was with my best friend when we were celebrating for my birthday. And I was like, I'm having a panic attack right now. And she was great because she struggles with them too. She's like, okay, just tell me what you need. There was no like, here, we'll do this, this, and this. It's just as simple as like, what do you need from me right now? And just like kind of writing that out. But yeah, that's how anxiety has really impacted those personal relationships, I think, like work and career goals as well.
Yeah, and I think sleep, like you said, is so foundational, and we don't often think of like things that are good for your body, like physical activity and sleep and getting outside and getting sunlight and eating well can also be good for your brain and for your mental health. So I'm glad you pointed that out. I also love the advice of just asking folks what they need in the moment, because you've done a good job of kind of laying your own kind of, I don't want to say boundaries, but kind of knowing what is good for you and what are your triggers. So what else would you suggest for people who have loved ones who are struggling with anxiety?
I think, that communication is just such an important portion of that, where just checking in with your loved one, asking them what they need. But I know with like where I was this past year, especially like in like October of last year when things were pretty bad, just being there for someone, like physically being present, can go a really long way. Like, I know how much it helped me. Like, my anxiety was so bad that my mom had to be the one to help me like get into the shower, which is like, I know like that sounds kind of weird, but it's like, it's just like anxiety can get that bad. And that's the point that I was at. But offering that emotional, that physical support, I know that I didn't want to go to therapy at times, and having someone be like, not being too pushy, but just being like, hey, like, like this can help. It really just being really gentle and like just showing up in different ways than you may have expected.
Yeah, and I appreciate you being so open and honest about that, because I think a lot of people listening will have experienced things like this or known someone who has. So thank you. You said earlier too that like when you're anxious, sometimes you may be irritable, and I think a lot of people take that as just being irritable, but it's actually related to the anxiety. So that's actually a good point for communication. Just to not misinterpret that's really going on. So again, be supportive is really helpful. What other tools or treatments or techniques have you found to be helpful for you?
Yeah. So for me, I've been involved with therapy since 2018, 2019. I've been seeing a therapist. But that therapist is not the same therapist. Like, I've gone through 4 or 5, maybe even 6.
Yeah.
And that's something I really wanted to touch on, because I hear from friends that are like, I don't know if I should go to therapy. Like, it's not like I want to die. And I'm like, you don't have to be all the way there to want to go to therapy. Like, you can go much earlier on. And another thing is if you feel like if someone's not a good fit for you, it's totally okay. Like, I've had this conversation with therapists. They're like, we don't take it personally. Like, that's part of our job to know that. And so, like, that's one big thing, like just being confident in that, maybe we're not a good match for each other, because this is a person who you're really going to have to be very vulnerable with. So you really want to be comfortable with that person. So therapy has been a pretty big one for me. I tried EMDR. EMDR was pretty intense and tough. Should I elaborate?
Yeah, I'd like to hear more about that.
So I can talk about like what my experience with EMDR was.
Sure.
I'll let you explain what EMDR is. But when I used to go in for EMDR, it was a lot of trauma-focused work, and using that as well, like a lot of techniques from EMDR and how to use those, like when you're in a high state of anxiety. But when I would go in, there was a light bar that was in front of me, and I would hold a very traumatic or emotionally intense memory. I would keep that in my head, and then I would just follow the light bar, And at the same time, I would have headphones on too, where you would hear the sound go from the left to the right. And it was a lot of that. And then towards the end, we would try to kind of pack it up and put it away, but it leaves you very raw. And the nice thing about EMDR is like you don't have to talk about what's going on in your life, which is at the time what I needed, where I just didn't want to talk about it. But I guess like I didn't completely understand like still how tough it is just to bring those memories back into your head and working through that. So that was EMDR, and I did try EMDR as well. I started medication, and this one took me some time because I had a lot of stigma that I put, I think, like on myself about taking medication. One was a benzodiazepine, so I was taking clonazepam, and my psychiatrist literally told me, he's like, you're like, it's slowing down the process of you getting better because of how much of a negative I don't want to say attitude, but just like negative beliefs that I had, that I was just scared. I'm like, what if I get hooked on to this? What if I get addicted to this? What if I can't function without it? And my mom was a huge driving force. And she's like, look, like I have to take a medication for my thyroid. If I don't take that medication, like I can't function. She's like, if you need to take antidepressants or if you need to take a clonazepam, she's like, it's okay to take that. And she really helped me a lot like this past year, because once I started to take the medication and my anxiety wasn't getting to the point of a panic attack, that was a game changer for me. I had to take medication to even be able to sleep properly because I was having nightmares every single night. And once that sleep started to settle in and I was sleeping properly, there was already such a huge improvement for me. So medication was a big one. And then the next sort of step was the lifestyle changes I was talking about, but exercise. And it doesn't necessarily have to be you're like going to the gym. It was as simple as going outside for a walk. And that really helped me a lot. But the number one biggest thing that now I'm a huge like advocate for is meditation. Mm-hmm. Meditation just changed so much for me, because the meditation that I was doing, it's like you have thoughts come up in your head, similar to like right now, like if I'm experiencing anxiety and I have thoughts coming up in my head, you just acknowledge the thought is there, but you don't put any judgment on that thought. You're not putting any pressure on yourself or any emotion on that thought, but you're just observing it and then you're letting it go. But you really have to train yourself to be able to do that. And meditation was a huge thing for me, where it really just let me sit down and it's like, okay, like I'm having this intrusive thought right now that is just very hard, and I'm just going to let it go. And there was just so much power in that, where it's like I'm not stuck fixating on that thought.
Yeah, you said so many things. I feel like we'd have to do whole episodes on each of those, especially meditation, which is so powerful. And one thing that you've kind of been describing this whole time is that it is probably a lifelong process, and it's work. Like therapy is work, trying different things is work, but you've been able to find some things that work for you. And I think that that's really helpful. And I know it's going to continue to be a process. So don't get discouraged, I guess, at home.
Right.
Like there are so many tools available. There's more coming down the pipeline that I think will be really helpful for a lot of people.
I think also like being in this lab and some discussions I had with my psychiatrist, one thing that he was talking about as well was like TMS as like one form. Like he's like, if the medications don't work for you, like it was just so like, you know, like when you're in that horrible place where you're like, I don't know if I can keep going forward with life because it's like nothing's helping. And he's like, we have just started. He's like, if medications don't work, he's like, there's so many other things, which is why it's so exciting. Cause it's like, like, we talk about like exercise in our lab, and then in the previous interview we're talking about neuroinflammation, and so there's just so much, and that's also very comforting to know that like you haven't tried everything yet, so there's still light at the end of the tunnel, that there's still something that could help you even if something hasn't right now.
Absolutely. Yeah, and I think, again, like shout out to sleep. I know sleep is really difficult if you're having these constant thoughts, but once you do get sleep in a good place, like things start to, I think, fall in line, because there are studies where they show that the amygdala, which is that emotional center of the brain, is kind of rebalanced after a good night of sleep, and like prioritizing like physical health and just taking that walk every day, if that's what, you know, helps you, just really taking the time to focus on your mental health. And that goes for people without psychiatric disorders. It should just be a part of just taking care of yourself, like brushing your teeth every morning.
Exactly.
So.
Yeah.
No, that's great. You also mentioned stigma, which is a huge topic of conversation for us on this podcast. This is something we're trying to do, is really break stigma. And you mentioned self-stigma, which is you possibly didn't even realize you had these negative thoughts or perceptions about things like medication and your own mental health. And I love what your mom said. Your mom is amazing, clearly. But she mentioned a good point that if you have like diabetes or something, you need to go to a doctor and get treatment. And for some reason, we think of these mental disorders as being like not medical conditions.
Exactly. Yeah.
There's also stigma at like the interpersonal level, and then there's institutional stigma as well. So what do you think about stigma? What can we do to help?
Yeah. Stigma, I have a very interesting relationship with it, as everyone's probably already heard. But yeah, like I think stigma also starts like exactly like you said, like at interpersonal relationships. Like my relationship with it was like, like 8-9 years ago when I was in high school. Like I don't know how much of a conversation there was about mental health, and I think the lack of awareness is a great way for stigma to sort of seep in. And I think that was a huge element at play, like at least like 10 years ago for me, and especially in the South Asian community as well, from like what I've seen around me in the community that I'm part of, where talking about going to therapy is not something you want to talk about. It's definitely gotten a lot better, but medication was a huge one, where it's like, oh, you shouldn't take medication for your mental health because you're going to get hooked onto these things, and these doctors are just trying to push pills onto you. And so you keep hearing that narrative, and I really think that things that we can do to combat that is really just start with educating ourselves. So podcasts are great too, but I think for me, like my way of sort of dealing with all of this is I am pretty transparent about my experiences with this. That's why I'm here. But even in like, like I remember Johnny Crowder says, it always starts at the interpersonal level. Like, what are you doing with the other relationships in your life? And that's where it started for me. Like, even at work here, like the fact that I could come to you and be able to be like, look, Hillary, like my mental health is just so bad right now. Like, I don't know what to do. And you really like helped me at that point where you were like, let's not make a big life decision right now, like while you're struggling with all of this. But it's like you have to create that environment for someone to come up to you and talk to you about that. And after everything that happened, like there are other people at work that know. And when they were able to hear about that, like the support that they gave, but then also like I saw that they were starting to talk more about what was going on with them. And then you start to learn, okay, so this is not just me that's going through this. And I feel like that's pretty empowering too. And that helps with the stigma as well, when you're hearing that others are going through similar things as well. And it's okay. Like, it's okay to go to therapy. It's okay to be taking medication as well. But having podcasts like this helps a lot too, because it really just, I think so much of it stems from awareness and the lack of awareness regarding all this.
Absolutely. Yeah. And the lack of education and just how far we have to go with that. But it is crazy. Like, if you share something personal about yourself, like if you say, I've experienced mental health disorders or symptoms, or I have a loved one who's struggling with depression or addiction, I feel like people just come out of the woodworks and they say, me too.
Yep.
So I think that itself is so powerful. And the fact that you're so transparent and sharing that with people that you know is also helping them kind of come to terms with that stigma.
Yeah, exactly.
What types of misconceptions have you heard about anxiety or mental health in general? I'm sure you've got a list.
Yeah, I've got plenty. I think the biggest one was about the medication, that it's like as if like medication for mental health is any different than medication for like physical health symptoms. I think also with mental health, we don't think about the physical manifestations of mental health as well. I've heard plenty about that, like, oh, like it's just in your head. Like you just gotta push through. Or like back in my day, there was no such thing as mental health. Like this is just some new thing that's being pushed on, and your generation is very sensitive. Like I hear a lot of that, and it can be pretty frustrating to handle, especially like when you're going through the thick of it. And unfortunately, I did hear that narrative from other people as well. So there's a lot of these misconceptions where it's like, it's almost as if like your mental health being bad is completely in your control, that there's nothing else going on within your body that could be involved with that it's just something that you're putting yourself through, that you're emotionally weak. And that has been a big one for me, like that misconception. Yeah, the stuff with medication. And then I think like people are just surprised, like on the other side of it, there are people that are huge on medication. They're like, I haven't heard much about like using exercise or meditation. Like they're like, you should be taking medication. And my psychiatrist is amazing. Like he's like we can start with either one. We can see what you're comfortable with.
Mm-hmm.
But seeing that meditation does help. Like I've seen a misconception plenty of times where people are like, oh well, that's not going to help as well as medication. I don't know what the research is on that, but yeah.
No, I think that that's important too, and part of it is having a good therapist or a psychiatrist too,
Yeah.
who's open to that, because there's a lot of differences between therapists too.
Yeah.
So again, having someone who you jive with,
Mm-hmm.
and yeah, with respect to some of those other techniques, like exercise and meditation can be as powerful or even more in some cases than medications.
Mm-hmm.
But of course, medications work for many people.
Yeah.
So I think like having a ton of options and figuring out
Exactly.
what works for you.
Mm-hmm.
Yeah, and you mentioned the fact that people don't know about these things, and maybe just kind of psychoeducation or just educating the public is something that we can do. And I think about epilepsy as an example where people didn't understand what was happening, that it was a neurological disorder. They thought people were possessed. So we've come a long way, and I think we're just beginning really to understand psychiatric disorders. We have some clues as to why they happen or who's likely to get them or not, but we don't totally understand that. And that's something that we're working on in the lab. But what can we do, you think, to improve that public conversation?
I think exactly what we're doing right now with like this podcast, but really just like starting that public conversation in whatever means that's involved. I think even with like how I'm saying like science communication is super important. And the reason I'm so passionate about it is because we are doing research to sort of tackle on some of these issues. But there's sort of this barrier that's there with the language that we use in research versus what the lay audience is able to understand. And that's why I'm so passionate about bridging that gap, because it's like, this, like, who are we doing this research for? We're doing it to help everyone, right? So others should be able to understand like what scientists are doing. And I feel like that's a big part too. And that's why I'm like, we should do infographics on publications and have these sort of series to explain what is trauma. And social media is a great place right now. There's so many people there, like on TikTok too, like you can just get a general audience and to be able to explain like what is the endocannabinoid system. Like that's something I learned about at this lab, and just like hearing, like talking to other friends that are like, wow, I didn't even know this existed. But yeah, it's like starting a dialogue and conversation about all this.
Yeah, perfect. And I think you alluded to the fact that scientists are not trained in how to do this. This isn't something that's typical. Like if you go to graduate school or medical school, you know, you're taught to speak the language and you talk to other people in your field. And what we're finding is that a lot of people can't even talk to someone in a different field, and that's an issue. So I think the whole field and institutions really need to adapt to meet people where they are and be able to actually talk in less jargon and make it more accessible. So I think we have a bigger thing to work on too. I want to, before we wrap up, go back to meditation, just because I think it's a very fascinating technique, and it gets a lot of bad rap, I think, because I think people just imagine like someone sitting cross-legged on the floor and it's like super boring, and they've tried it maybe once or twice and they don't really get it. And I think like back to what we talked about earlier, that it's really a process and it's really about the actual practice itself. And you actually took something really beneficial from that. So I don't know how long it took you. I'm sure it takes people different amounts of time, but it's not really about meditating. It's about realizing something about your mind itself. So could you speak a little bit more about that?
Yeah, I think like when I actually started meditation, and this is something, because I was like, why am I struggling so much with just sitting down and doing this? And then you see so much of that where people are like, do you get more anxious like while you're sitting down and doing this? I had a conversation with my psychiatrist. He's like, sometimes that does happen. Like he's like, you're going to sit down. He's like, you're going to be paying attention to your mind. So you're going to be focusing on a lot more of those thoughts. So it really did take me time. Like I started back in, I want to say November, with heavily like just like 5 minutes every day. And I think it's all about the baby steps, like just starting really small. So like I started with like, I think 2 minutes at first, then 5 minutes. And it was really just like, I was sitting there, and I started with guided meditations at first, because I was like, I'm not entirely sure what I'm doing right now. And then eventually, once you get the hang of it, which is really just, I believe that's called open monitoring in research, when it's like you notice the thought and then you just let it go.
Yeah,
There's like
just
open
observing.
monitoring versus focus
There's a
attention.
lot of different types of
Okay,
meditations.
yeah. So for at least for the one that I do, like it definitely took me time, and it took months. Like I want to say like 4 or 5 months to be able to get to a place where now I can just sit there and really get into that zone pretty quickly. But in the start, it took way too long, but you feel it immediately though, like being able to ground yourself. Like for me at least, like I felt it immediately where I was just sitting there and I was like, okay, like these are just thoughts in my head. And that was one thing that my psychiatrist kept explaining to me. He's like, these are just thoughts. And to be able to sort of take the weight off of those thoughts, and that's what meditation does a lot for me. There's so much power in that because those thoughts begin to feel like reality with the anxiety. So it's really just like, yeah, you have to be patient with it, but once you're able to slowly build yourself, it's just like if you're starting an exercise or you're starting to lift weights, like it's like you got to start small and you got to start somewhere, but eventually over time you'll see that growth.
Yeah, I think that's wonderful. And a lot of people, they get it quickly. They get it in years or decades even. So everyone's different. But yeah, I think the realization that you got that thoughts are kind of like, I always think of it like a stream. Like they're just going to keep coming and you don't need to hold on to them.
Yeah.
So that realization and just paying attention to how your mind works, I don't think many people have done that before.
No.
So
I definitely didn't.
No, I mean, it's an educational thing. And I think eventually the idea is that it would kind of penetrate into your life on a daily level. So when you're driving, your mind is not wandering as much but yeah, I think it's more about like learning kind of a new technique, or I always think of it as like learning to read a book. Like it just opens up so many different pathways and opportunities for you because you have an understanding of how kind of your mind works in your brain.
It slowly, you begin to incorporate it in your life, exactly like you said. Like what I'm doing, like sitting down is maybe what's the most stereotypical meditation sort of technique. Now I'm doing it when I'm walking. Like it's like you can incorporate it in so many different things, but eventually you're not thinking about it, but it is so much of like getting into the habit of it and habit of seeing your thoughts that way.
And training your brain to do that more easily. Yeah. And I think for folks who want to get started, you mentioned a couple of other ways to do it, like just taking a mindful walk. There's mindful eating practices. YouTube has a bunch of different things. There's Headspace, which is a great app to get you started. So do you have any other suggestions?
No, I think exactly what you said. For me, I started with YouTube actually, and I actually started with guided meditations while I was going on walks and like focusing on like the sound of the birds or like feeling the wind on your skin. But I started there because for me, it is hard for me to sit down and stay still, and it can be pretty difficult. So I just started with free resources online, and I can definitely send you links to some of the ones that I use, but it's all out there. There are so many like really great like free apps too that I personally used. I'll send those as well. I can't remember the name, but I remember like there was one app that I used to track my emotions and then also track my like guided meditations as well. And it's like really cool because over time, like hopefully if you're starting to feel better, it's really just nice to see that trajectory.
And just to kind of tie it all back together, in the beginning we talked about anxiety being really future oriented, depression being more kind of stuck in a rut of the past, and the goal is really to stay present. And people have actually shown with studies that if you're in the present more often, you're actually happier. So it's a very powerful tool, and it actually turns down that default mode network, which we mentioned in the beginning, which is, we think, implicated in depression as well as a variety of other disorders. So there's definitely a neurobiological basis to it. I guess let's wrap up and share any advice or resources for people struggling with anxiety or have loved ones or any mental disorder.
Okay, I'm a huge advocate of Psychology Today. Psychology Today has like a bunch of really nice articles, but the biggest thing for me is that's where I found my therapist and my psychiatrist as well. You can put in your insurance information. You can put in exactly what you're looking for. Maybe you want someone that knows how to work with LGBTQ plus folks, and you can check all these different things off and really find someone that works for you. And then for my advice in general for maybe individuals that have loved ones that are struggling with anxiety, exactly what I said before, that it always starts with that communication and just checking in. Like, that's always going to be my big word of advice. Just check in, see what that person needs in that moment. It could be different right now than maybe like an hour later. So just start with that conversation. For those that are struggling with anxiety, I remember I wish I had someone tell me that like it does get better. Try not to get emotional. But yeah, it's like it does get better. It just takes a lot of time. But when you put that work in it, yeah. We're going to have to cut this part out. Yeah, we're going to have to cut that part out. But yeah, for advice with people that are struggling with anxiety, it takes time, but it does begin to get better. It's therapy, like, yes, you showing up, like you're showing up for yourself. And then there's a lot of work that happens outside of therapy too. And take time to just acknowledge what you're doing for yourself, because it takes a lot of strength. It takes a lot of strength to get to where you want to be, but you'll be able to get there.
Yeah, and I am so proud of you in so many ways, but thank you so much for sharing, and thanks for all of your work over the many years we've known each other.
Thanks for having me.
All right, Dr. Fang, thank you so much for joining us for our episode about anxiety disorders. Can I first just ask you to briefly introduce yourself?
Sure. Thank you so much for having me. So I am director of a lab called the Center of Neuroscience, Neuroendocrinology, and Clinical Translation at the University of Washington. And I'm a licensed clinical psychologist and a neuroscientist, and studying the ways in which people process social and cognitive social information in the environment as relates to anxiety and obsessive compulsive disorders. So yeah, we use lots of different methods in our lab to look at those mechanisms, but ultimately interested in improving treatments and developing novel ways of helping patients with these conditions.
Awesome, and I'm excited to get into those techniques later on. So this has been a huge topic of conversation with COVID. You know, we always talk about if the prevalence and kind of the severity of mental disorders, including anxiety, if that's increased since COVID. So can you first start off by telling us how common anxiety disorders are in particular, and if they've actually increased, since COVID?
Sure, yeah. Yeah, so anxiety disorders are extremely common. It's just about on par as mood disorders. And yeah, I would say that with COVID, I think it's hard to determine if it's really increased or if it's really just that people are coming out more and, sharing more about their experience, or that it's people are just talking about it a lot more. But it's definitely there have been reports that COVID has exacerbated anxiety. I follow the OCD literature quite a bit, and you could think about contamination fears in this population, that people with contamination fears and OCD have really felt so validated the past couple of years that now the general population kind of understands what they've been dealing with all along. And it's kind of normalized some of the cleaning procedures and thoughts about risk and harm that come to their minds quite often. But yeah, I would say it's pretty hard to say. I would say I've read some reports in the adolescent population that there's definitely been increased rates of anxiety there during the last couple of years, and that it's affected boys and girls, school-age boys and girls differently too, just in terms of staying at home and not getting as much of that social interaction at school. So it seems like some of the longer term mental health impacts are coming out now. But as far as whether the prevalence has actually increased, I think that's a really hard determination, and needs to be looked at on kind of a larger scale. And I think more of that data is going to be coming out.
Right. And as you mentioned, like specific age groups or different like genders, potentially there's differences. So a lot of work to be done. Can you tell us a little bit about the different types of anxiety disorders? I think that's something that a lot of people don't realize, that there's actually different types, and then how they're diagnosed.
Sure. Yep. So there's so many different types. The most common that people talk about are social anxiety disorder, specific phobia when it's more concentrated on one particular area, like heights or getting injections or shots. And generalized anxiety disorder is also very common. Panic disorder, agoraphobia. These are kind of the canonical anxiety disorders. But there's also another group of what I consider to be anxiety disorders that the Diagnostic and Statistical Manual has more recently categorized in a totally different spectrum of disorders. And that's the obsessive compulsive spectrum. And now PTSD, post-traumatic stress disorder, is also on another spectrum as well called stress-related disorders. And so people who aren't familiar as much with the research kind of now wonder, are they not anxiety disorders anymore? Are they, now that DSM has put them in a different category, does that mean they're not? And actually, I think the most important distinction is just whether the disorder is fear-driven or not. And even in the same disorder, there could be folks who don't have as much fear. And so it's a very heterogeneous group of disorders. And you can kind of look at it on a case by case. But I would say in general, these canonical anxiety disorders, OCD and body dysmorphic disorder in particular, and PTSD are driven by a lot of the same types of fear-related mechanisms. And so I see them as all being anxiety disorders.
Yeah, that's really interesting. And part of your work is in the neuroscience of these disorders. So that's something we'll get into in a moment. But it kind of brings up a question of, you mentioned these are very heterogeneous. They all share this kind of fear-related basis and anxiety basis. Is it possible to have multiple of those at the same time or throughout the lifespan?
Yes, that's actually much more common than to just have one of them. Yeah, simple phobia or specific phobia is I guess it's more common in the sense that everyone has a simple fear that can become maladaptive in a certain situation. Like public speaking fear is the most common specific fear, but it's just kind of called under social anxiety disorder. But yeah, it's much more common to have multiple ones of these, and the likelihood that you have more than one is higher when you have one. So yeah.
That makes total sense. And in terms of like the diagnosis part, how do they actually determine like if it's one or the other, or how does that work?
Yeah, so unlike other kinds of medicine, I would say psychiatry is kind of still in the dark ages. We still sit in a room and interview folks using, fairly structured interviews based on what we know about symptom presentation and course and onset of illness, things like that. But it's still based on clinical interview, and so this is done through mapping symptoms onto kind of a list that is prescribed in the Diagnostic and Statistical Manual. And so it's through training in structured clinical assessment on these interviews that you get that diagnosis. And it's usually done by a clinical psychologist, but it can be done by other trained clinicians, and often by psychiatrists as well who have a medical degree. And they might be accompanied by other self-report measures that are really psychometrically sound, meaning that they've been tested in these clinical populations and really validated to assess how severe the symptoms are. So that's really kind of the best clinical tools we have, which sounds kind of like ancient in comparison to some of these other aspects of medicine where you're getting a scan, blood work done, and other assays, and we're just not there yet.
Right. But I always say it's an exciting time to be in psychiatry because we have a lot of those things hopefully coming down the pike. And also, I always say that like psychiatry is like a science and an art for that very reason that it's really a lot of that. You really need a lot of clinical expertise and experience. So, very, very interesting. Thanks for explaining that. You mentioned a lot of different types of anxiety disorders, and I'm sure they come with a lot of different types of symptoms. So, can you describe, common symptoms across those disorders, or specifically for a given one?
Totally. Yep. So social anxiety after specific phobia is probably the most common anxiety disorder. And this is a fear of being negatively evaluated in a social context. So this isn't just, being afraid of public speaking, although if it is just focused on just that one fear, then that is also very common. But if you never have to give talks, then it's probably not interfering, and then it's not really considered pathological or rising to the level of needing clinical attention, right? So when we think about diagnosing these disorders in these clinical interviews and self-reports, we're often, aside from assessing symptoms and whether they are meeting criteria for the symptoms, we often consider severity, frequency, intensity, duration, and those things help us understand interference in anybody's particular day-to-day life. So someone who has a public speaking fear but, works at a zoo, you would never imagine that that person probably is experiencing
Right.
dysfunction at work.
Zebra isn't judging you. Hopefully not.
Exactly. So sometimes it's about that match, right? But so social anxiety is really described by that fear of being negatively judged by others. And usually the common fears are rejection, being seen as unintelligent, being kind of inadequate or awkward in some way, just not fitting in, not being liked. So those are the real common fears with social anxiety disorder. And the biggest feature of this is just pervasive avoidance of social situations. The first thing to go is probably optional social gatherings, right? And then when it starts to get really interfering are things that are more mandatory, like school or classes if you are a student, or, missing out on work if you're, working, and then it goes from there. Generalized anxiety disorder is also very common. This is, I think, contrary to popular belief, this is not just worrying, because there's a lot of people out there who worry. But this is considered more of the worry disease, where you have very persistent chronic thoughts about bad things happening. And these are more day-to-day things that aren't really irrational. When you think about it, it's like, well, I'm going to be running late to my appointment. I better look up the directions and, figure out parking. And there's lots of things to worry about going wrong. And the fear is often really hard to get your hands around. It's often very abstract. Sometimes people can't even describe what the real fear is, of like what's the worst thing that could happen. But I think the most important thing for understanding how to diagnose GAD is that the level of worry needs to be disproportionate to the circumstances, meaning that it's happening more days than not. It's really hard to control once it starts. It might interfere with sleep and just have lots of other somatic complaints that go along with that, like fatigue and feeling keyed up or agitated can go in either direction. But also, if someone has like a medical diagnosis of cancer and they've got a lot of interpersonal stress at home, lots of, stuff going on with kids or, family, and maybe they've also recently lost a job and there's just other life stress, you would imagine someone in that situation would worry a
It would
lot.
be
And
weird to not worry.
that's really adaptive, and that's actually really important to see that response. But what we're talking about is a disproportionate level of worry beyond what's going on in someone's life. And so that's going to be based on a clinical judgment that's different for every case. Um, And then panic disorder and agoraphobia are really linked. These are also fairly common too. It's marked by persistent panic attacks. And these are not just anxiety attacks. A lot of people will describe just having a lot of constant anxiety, but this is a panic attack is an onslaught of physical symptoms that rise within 5 to 10 minutes and peak. And it's limited symptom attacks can sometimes be even hidden. You can't even see that someone's having a limited symptom attack. Characterized by 4 or more different types of symptoms like heart racing, sweating, feeling hot, things like that. But some of the larger panic attacks come along with a lot of the cognitive symptoms of, I think I'm going to die, and something's really wrong with me. They might feel like they're dissociating from their environment, that they can't process anything. It's really, when you're having a panic attack because you just are totally losing touch with reality for those 10 minutes. And so when it's cued, it's a little bit different because social anxiety, for example, can trigger panic attacks. But if it's always triggered by a social situation, it's not really considered panic disorder. And so those are just cued panic attacks. And they have a different type of presentation than panic disorder, where it could totally come on out of the blue. You could just be hanging out in your house, things are fine, and then suddenly it comes on out of the blue. And so the avoidance there, the way people cope, is to avoid just the physical symptoms. They might avoid caffeine because it ramps up their heart rate. They might avoid running at the gym, any cardiac activity, because it just brings on the potential symptoms of those feelings. And agoraphobia is when it just starts to bleed into crowded situations or places where you might have those symptoms and you can't get out. So like a concert or a game or, things like that, where even a mall, like I won't be able to really escape, or no one will be able to help me if I suddenly have one of these panic attacks, or other physical symptoms. And so they really go together, although they can be diagnosed separately too.
Wow. I just want to say I also study anxiety disorders, but I've never heard a more beautiful explanation of all the
Oh,
types. That was a really good explanation, and you really painted a picture of what it's like to have those different disorders and just the variety of types of symptoms and experiences, and that different types of almost triggers or things can cause one to have those symptoms. So thank you so much for that. I want to talk about risk factors. So what do we know on that front?
Yeah. Risk goes hand in hand with your other thoughts about just when it tends to start. And so in early childhood, I would say the earliest risk factor that's been more reliably studied is behavioral inhibition. And BI is often associated with negative affectivity. That's another kind of really, like, what do we mean by negative affectivity? It's a really broad construct. But people talk about these temperament factors that have strong genetic loadings. And BI, NA, behavioral inhibition, and negative affect are 2 of these temperament factors that have been really well studied in anxiety disorders. And what it reflects is really like a hesitation or reticence in the face of novelty. So kids, when they're, introduced to a new situation, when they display behavior inhibition, they're just really slow to want to explore that novelty. And just, just being a little more reserved. It can present as shyness. It could present as being a little more reserved or just unsure. And that's one of these risk factors that have been looked at least when you're talking about early in life. There have been a million other types of psychological constructs that have been studied that probably don't rise to the level of those temperament factors just because they don't have as much of the genetic and other biological associations. But I would say anxiety sensitivity is another one that's gotten probably a lot more research in this area, just meaning how sensitive somebody is to the physical and the cognitive components of anxiety. And that ASI, Anxiety Sensitivity Index, that's a very popular measure to look at risk as well.
Mm-hmm. Anything with like parenting or environment that we should know about?
I I would say so. This is probably an area I don't study as well because I just have kids. I don't. I always say that
You
to
don't
my
study them?
patients. I don't study them. I don't really know as much about children, but yeah, as far as parenting, I think there have been studies on um, intergenerational transmission of anxiety and how anxious temperament or anxious practices in adults can transfer onto children. And there's lots of ways that's probably happening through modeling and observational learning. Um, and my patients definitely ask about that. My patients with kids ask about that. Like, how do I prevent that from happening to them? And so, yeah, I would say that the risk factors there, I think there is an increased risk if there's parental anxiety on board in the mom or the other partner or parent. And so, yeah, I'm just a little bit less familiar with that literature, but definitely has been studied as well.
Yeah, and that's interesting that your patients bring that up as well.
Yeah.
So they're also like they're anxious about that too. Um, what types of evidence-based treatments do we currently have for anxiety disorders?
Yeah, so the most empirically supported is a set of interventions called cognitive behavior therapy. And why I say a set of interventions is because this literature is so big that people have carved out individual manuals of CBT for specific disorders. But at the end of the day, it's the same types of principles. And an easy way to describe it is that CBT is cognitive behavior therapy. There's a cognitive element, meaning that there's problematic thoughts that are contributing to your distress, and then there's problematic behaviors that are contributing to your distress. So the treatment really follows the patterns of thinking and thinking and behavior that are maintaining your symptoms of distress. And so the treatment is starting out looking at an individual formulation of those patterns of thinking and behavior that are maintaining that distress, and then targeting that in actual strategies. Outside of that, a lot of evidence-based interventions include mindfulness interventions and acceptance-based interventions. I guess there's a group of what people call third wave interventions after CBT. So these include mindfulness interventions, acceptance-based interventions, dialectical behavior therapy, improves anxiety, metacognitive therapy also improves some attentional practices that might maintain anxiety disorders. Yeah, there's a whole host of them that have garnered a lot more attention too, but CBT is just hands down the first line intervention for anxiety. And it's exposure in particular. I guess you could think of exposure therapy as hitting on the B components of CBT really, really strongly, but good exposure therapy also integrates the thoughts and is really a CBT at the end of the day. So exposure therapy, hands down, is what you need if you haven't had it before for anxiety disorders.
Mm-hmm. And how does things like medication, how does that play a role into that treatment plan,
Yeah,
generally speaking?
yeah. The literature on medication alone is just about on par with CBT for anxiety disorders, if we're talking strictly anxiety. But the long-term consequences, it starts to fall short. So it's only as helpful as you continue to stay on the meds. Whereas with CBT, it has so much better follow-up data and follow-up results because you're basically teaching patients to have a whole new way of living, and that becomes like the new standard, the new habit. And so the follow-up data are so much stronger for CBT. And then of course you have those patients who are just so ill that there's no maybe there's not as much, maybe here's more of the art of the psychiatry than the actual science, where if they're so ill that they're not coming into session and not able to really engage in CBT, there's a real time and place to consider medication, because it might just get them activated enough that they can come in and actually engage in the treatment.
And do the work. That makes total sense. All right, I want to talk about now the biological basis of anxiety, and I know this is something that you do a lot in your own work and what's happening in the brain. So, can you just tell us a little bit about what we know about that?
Yeah. Yeah, the neuroscience of anxiety disorders is so interesting to me. I guess I'll preface this with the kind of groupings of anxiety that I started off with, which is the canonical anxiety disorders, your obsessive compulsive disorders, which I think of really OCD and BDD, and then your PTSD related disorders or stress related disorders. And the neurobiology in general for these disorders fall along a couple of different brain circuits. So one of them is called a corticolimbic or frontal limbic circuit, meaning it's abnormal interactions between executive functioning areas of the brain, cortical regions, and then the more subcortical limbic regions of the brain that process emotions and deal with the salience of the environment, cues that you should be paying attention to that are threatening. So most of the research on anxiety has shown that there's abnormal interactions between the frontal and the limbic areas of the brain, mostly showing that the limbic areas are really, really responding overly so, and that the frontal regions are not inhibiting those areas quite as much. With OCD and BDD, the literature has focused a little bit more on the repetitive compulsions that are present in these disorders. Although I still think of them as fear-driven disorders, the data on the frontolimbic problems there are not as consistent as with the canonical anxiety disorder. So even though there's like broad commonalities across these disorders, there's also real differences. And the OCD and BDD disorders are more focused on corticostriatal problems in the brain circuits, which are focused on more of the reward-related regions of the brain that go awry. And again, that's related to those compulsive behaviors that we see in OCD and BDD, because these disorders are really driven by more repetitive behaviors to cope with their fears. And then PTSD is just all over the place too, in terms of frontostriatal, frontal striatal also. I think they're all based on a particular presentation of the combination of symptoms that you see. But those are the two most common brain circuits, I would say, that have been looked at in anxiety.
Mm-hmm. And it's nice to hear you talk about like brain circuits and how different brain areas are communicating with each other. Because I think a lot of people don't think about that fact. They think of like, oh, there's an anxiety area in the brain. But what you're describing is more like a network type approach, right?
Yes, exactly. Yeah. I think neuroscience has moved a long way from just one area. People used to always say, oh, my amygdala is just way too overreactive. And we've moved a really long way from that more simple way of thinking about threat and anxiety. It's really about a bunch of areas of the brain communicating with each other, and where in that process is it going awry.
Yep. The brain is complicated, as we know, and a lot of that progress that we've made is due in part to a lot of the different techniques we have available as neuroscientists. So things like neuroimaging. In your lab, you use a lot of different techniques. I was impressed reading about all the things you do. You do neuroendocrine analyses, you do pharmacology, you do behavior, you do neuroimaging. So I'd love to hear a little bit more about what you're up to and what you're most excited about in this area.
Yeah. So I've been excited about this podcast because I'm able to share that my thoughts on the transdiagnostic nature of a lot of these symptoms and these phenotypes, but it's also somewhat disorder specific too, and there's some important differences between these disorders. So in my lab, we're really interested in looking at commonalities across anxiety and obsessive compulsive disorders in particular, OCD and BDD. And we're using imaging to look at that. I'm interested in the ways that individuals with these disorders process social information from the environment. So I'm really interested in social anxiety in particular. That's kind of how I started off my work in a graduate school lab that focused on social anxiety. And we would run social anxiety groups at night, and just it really spawned a lot of questions I had about how anxiety works and how it's maintained. And it's transferred over into OCD and BDD as well. And so I've been really interested in the ways that people process social information. And so those questions naturally led to what are the biological underpinnings of that. And we were interested in the oxytocin system because of the way that this neuropeptide regulates social behavior and attachment. And it's gotten a lot of good and bad press, I would say, that this is the love drug, it's the cuddle hormone. And it is a hormone, but I would say it's a neuropeptide because it has both central and peripheral effects, meaning it acts on brain central parts of the brain and also in the peripheral circulation. And it's just got it's a huge repertoire of effects. And it focuses on social behavior, social cognition. And so we're really interested in the ways that the oxytocin system might be disrupted in people with anxiety. So yeah, we've taken blood samples. We've given them oxytocin in a nasal spray form because that's been shown to give supraphysiologic doses. That's what they call it, just like biologically implausible doses of oxytocin to their brain. And for a while, it was unclear if it was even reaching the central targets that we were hoping for, because the receptor distribution in the brain is so broad. Its receptors are all over the brain, frontal regions, subcortical regions, brainstem regions. But there's been really strong translational evidence now that it actually does reach the central targets when you administer it intranasally. And so I've been really excited about that combination of strategies. Can we manipulate it when we give these really high doses of oxytocin? And then can we also measure it in the blood to look at just more basally? I haven't done it in the context of a symptom provocation type of study, meaning that you make them really anxious and then you measure the oxytocin, but that would be a very important step. That's where they've often seen oxytocin differences in anxiety disorders compared to controls, is when you provoke their anxiety. And that's often the case for anxiety disorders in general. So yeah, so that's an exciting line of work.
Yeah, I love that too. And I think our listeners will be kind of pleasantly surprised that things like an intranasal spray are being, investigated for a mental disorder, which is so crazy. We're having a podcast episode about brain stimulation. So, again, it's a really exciting time to be in our field. And I'm just excited to see what you find, because that sounds like a really awesome way, instead of taking a medication or, therapy is great, as you said, but it doesn't work for everyone. And there's definitely room for improvement, right?
Yeah, exactly. That was totally my interest in oxytocin. It's just such a, both men and women biologically have this hormone. And the side effect profile is just so much better than the other pharmacologics that we have for anxiety. People are really just on face value really interested in oxytocin because it's something we already have. It's not this synthetic thing that you're giving them. Actually the compound that we use is a synthetic compound. But yeah, I would say that the literature though is very, very mixed, and there's a lot of controversy around oxytocin as an actual translatable drug because its receptor distribution is so nonspecific. But I still think it's worth investigating. At least the NARSAD Brain and Behavior Research Foundation's study that we just got awarded, I think is a really interesting twist on how to use oxytocin, because we know that its effects definitely are in the social domain. It seems to boost responses to social stress really well. And so I tried to leverage that literature to understand, well, how can we actually use it clinically? And the studies on its anxiolytic properties, meaning does it just have anxiety reducing effects, is really not very strong. Some people are saying that it actually can enhance anxiety, and it can have polarizing effects. And we saw that in our studies too, that depending on the type of person that you are, if you have certain bad attachment history, meaning that you've had traumatic experiences in the past, particularly interpersonally, that can really change the way that oxytocin affects you. Sex is an important moderator too, that it seems to affect men and women differently. So as far as its universal anxiolytic properties or anxiety reducing properties, it's really not good for that. So instead, what we try to do is leverage the fact that that oxytocin seems to enhance responses to social stress more reliably in animals and humans. And what we wanted to do is see if you can enhance the kind of observational learning component that can happen in exposure therapy, meaning that you're often learning from others how things that you previously thought were fearful now become safe. And in the context of therapy, you're working with a therapist to model safety behavior. In the context of approaching a fear, like in social anxiety disorder, you'll often, go up to a stranger and ask them for $50 or something, and do something just totally scary because you could be rejected. And in that type of exposure situation, the therapist might model for you how you can do that. And you might learn through that therapist's experience, oh, they're okay, they survived, they're not breaking down from all of that anxiety, that, oh, okay, I'll be okay. And it's through that transfer of learning that might be even better for people who really just don't want to try exposure therapy, because learning direct extinction is really quite scary for a lot of folks, and people just don't want to go through that. So if you can learn from others, and then can oxytocin potentiate that process, that's I think a really cool clinical indication for oxytocin, because it's through a mechanism that makes a little bit more sense than just universally making everyone less anxious, which it's looking like oxytocin is not going to be useful for that.
Right, very specific situations. That makes total sense. And congratulations on that NARSAT, or the Brain and Behavior Award. That's a very prestigious award in our field, so congratulations. We'll have to have you back in a couple of years to see what those results look like. I do want to end with the question of what resources you would suggest for someone who's either struggling with an anxiety disorder or maybe knows someone or a loved one. What would you suggest?
Yeah. I think people are looking to the internet a lot more. And the Anxiety and Depression Association of America, ADAA, not to be confused with the Dental Association. But the ADAA is a really great place to start, because there's some rich information, sometimes in multiple languages actually, on their website for resources. And then the Association for Behavioral and Cognitive Therapies, ABCT, is kind of the largest, at least in our country, organization for CBT and evidence-based interventions for anxiety and mood disorders. So I would definitely start at one of those two places for seeking help. There's even therapist directories in both of these organization websites where you can search specific factors, even insurance, that you can look up within a certain proximity to where you live.
That's wonderful. Yeah. And the fact that, you want to find someone who has these evidence-based tools in their toolkit, like cognitive behavioral therapy, is really important. So thank you for mentioning that. And thanks for mentioning those resources. And thank you for coming on the podcast, Dr. Fang. This was wonderful.
Thanks for having me. This is awesome that you're getting this information out to a broader community.
Thank you so much. I appreciate your time. That wraps up another episode of the Brainstem podcast. Thank you so much for listening. Please subscribe and share this with friends and family, and be sure to follow us on social media at Brainstem Podcast.